Welcome to Chapter 4, and what a long chapter that last one was, covering all the drugs in one chapter. Just a reminder that your final project will be for you to choose one of the drugs and to write a research paper and to create a PowerPoint educational presentation. The final project is worth 50 points and is due on December 13th. See the instructions on the final research project in the Files menu on the left under Assignments. Now, on to the Assessment of Substance Abuse, Dependence, and Addiction, Chapter 4. I need to acknowledge that this chapter is quite out of date from normal practices today. I will be lecturing and teaching the newest forms of screening, assessment, and level of care placement instruments. I will be discussing diagnostic criteria for substance use disorders using the DSM-5 criteria. Other areas that are out of date, the stages of change, need to be covered in addition to the defense mechanisms in this chapter. This lecturate may deviate from Chapter 4 in the textbook. You will be quizzed on this lecturette as opposed to the out-of-date material in the chapter. In this chapter, we are going to be covering screening tools, assessment instruments, and the diagnostic criteria for substance use disorders and level of care placements. We will look at defense mechanisms, coping skills of the addict and alcoholic and the family members. I will also lecture on the stages of change in addition to the defense mechanisms. We will identify important alcohol and drug screening and assessment questions. In the Files menu on the left-hand side, there under Handouts and then Chapter 4, are samples of screening tools and assessment instruments. Assignment number 2, which is due November 18th, is to interview someone that you don't know about their alcohol and drug history. You may pair up with another student in the class if you wish to do this assignment together, or you can choose to interview someone from outside of class. Consider using one of the standardized screening or assessment tools. See further instructions on assignment number 2 in the File menu on the left-hand side under Assignments. We will take a look at the differences needed in the assessment of substance use disorders for adolescents and the current criteria for teens at risk of developing SUD, substance use disorders. In this chapter, we will explain the relationship between substance use and suicide. In the last chapter, you may remember you were exposed to the definition of addiction as proposed by Dr. David Smith, using the 3 C's to describe the symptoms of addiction to any drug or behavioral addiction, such as eating, gambling, video games, spending, and other activities. This definition is more functional and can be understood by many of the patients in the program. However, in more clinical terms, in the Diagnostic and Statistical Manual, 5th edition, called the DSM-5, which came out in 2013, substance-related disorders are now in 2 categories: substance use disorders, SUD, and substance-induced disorders. With the release of DSM-5, many previous common terms associated with addiction became obsolete, including the term addiction. In the past, we talked about substance use, abuse, and dependence, and trying to determine when substance use became misuse or abuse. Many people also did not like to be called addicts or addiction, and the stigma surrounding this word created discrimination. Today we use substance use disorders, and you either have it or you don't. If you do have it, then you may have mild, moderate, or severe symptoms. The DSM-5 gives 11 criteria or symptoms for substance use disorders. The more symptoms that you have, the more severe the SUD. Each substance is rated independently on the 11 criteria. For example, you may have a severe opiate use disorder, but a mild alcohol use disorder, AUD. Each substance that we reviewed in the previous chapter would be assessed to determine whether the person sitting in front of you has a substance use disorder and the rating of the severity for that disorder. See the handouts in the Files menu on the left under Chapter 4 for the substance use disorder criteria from the DSM-5, including the 11 criteria. Substance-induced disorders are individuals who are intoxicated or who are going through withdrawal while they are sitting in front of you. It should be noted that the term detox is no longer the commonly used phrase, but rather withdrawal management. Detox implies an acute state that is over and done with, whereas in reality, many withdrawal symptoms can last up to a month or more, given the substance and the frequency and the amount of the use of the substance. Therefore, withdrawal management is managing the symptoms over time. The most common defense mechanisms associated with substance use disorders are minimization and rationalization. Minimization is lessening the severity of the symptom. It's not that bad. It could be worse. I'm not as bad as the homeless person who drinks all day. Those are examples. Rationalization is coming up with reasons, quote unquote, for the drug use that the client actually believes. For example, my divorce was really hard on me, so I started drinking. Defense mechanisms often have some modicum of truth that is taken to an extreme. The more severe the SUD, the larger the defense mechanisms need to be to cover or deny the symptoms. Defense mechanisms affect not only the client, but the family members, friends, and even society, who all make excuses for the client's drug and alcohol use. Unfortunately, the defense mechanisms protect the client from the realities of their SUD and may make it hard for the individual to accept help. In this manner, then paradoxically, while the mechanisms protect the individual, they also prolong the symptoms and make the consequences even worse in the long run, including the risk of death for the individual goes up. In the old days, we used to say we have to wait until the client hits bottom, and that there is nothing that we can do to help them, quote, until they are ready, unquote. Unfortunately, as a helper in the addictions field, this demonstrates a helplessness that further perpetuates the strong defense mechanisms. If you really believe in this old way of thinking, please consider the consequences to the individual. We need to do everything we can to save the person's life. Make no mistake that working in the alcohol and drug field is about life and death. As a helper, we need to speak up. We need to state our observations to the individual and to the family. We no longer confront or break the denial, as this would just push the client to walk out the door. With stages of change and through the use of motivational interviewing, we come alongside the client's resistance and caringly support the individuals while stating the observations, reflecting what we are hearing the individuals say, or the discrepancies that we see in their behavior. The stages of change were developed by Prochaska and DiClemente while researching individuals who were trying to stop smoking. They discovered a universal process that individuals go through in their process to stop smoking. Some people are in the pre-contemplation stage, aka denial. This individual has no awareness of a problem and therefore no need to change. Contemplation is the stage wherein the person is willing to explore some small steps of change, but probably in the next 6 months or so. I will start exercising after the new year. The holidays are so busy, I can't do anything about it until then. Individuals in the contemplation stage may acknowledge some problem, but may not know how to make the change. When you work with the individual providing education on the steps needed, what do you need to do to get ready to start exercising after the new year? This becomes the preparation stage. The action stage happens when any small step has been implemented by the client. When the individual has been making changes for more than 6 months, the person may move into the maintenance stage. The stages of change are not linear, and individuals may go backwards or forwards. They may also go all the way back to the pre-contemplation stage when the client relapses. More on this topic in Chapter 8. The goal is to move the client through the stages of change, one stage at a time. As helpers in the alcohol and drug field, it is our goal to actively work with our client towards health, wellness, and recovery, no matter how much the client may be in denial. We take what we can get in terms of client movement and then keep moving. The progress may be slow and may take a long time. The textbook describes treatment in a 28-day inpatient facility that is not effective because it's not long enough, which is why the 28-day facilities no longer exist, because they're not covered by insurance anymore because they were not effective. Most treatment episodes need to last a minimum dose of 90 days. But the treatment benefits continue up to 18 months. The research shows that the longer the individual stays in treatment, the better the health, wellness, and recovery outcomes. Screening answers the immediate question: does this person have at least one substance use disorder? Does this person have any immediate needs that need to be addressed prior to treatment, such as withdrawal needs, history of seizures, unresolved medical issues, suicidal ideation, mental health history for medications, unsafe living environment, which may indicate a need for residential treatment. Assessment answers the more comprehensive and diagnostic questions. Does this person have a substance use disorder? What severity? How many substance use disorders? Prior history of treatment? And what has or has not worked in the past? What level of care will this person benefit from? What have been the consequences to the substance use disorders? Do any of those issues need to be addressed right away? An assessment can also include the use of structured assessment tools, urine drug testing, and perhaps even a physical to determine the impacts that the drugs and alcohol have had on the person. A comprehensive treatment plan will follow from the assessment. What areas of the person's life needs to be addressed during treatment and in what order? Each person will end up with an individualized treatment plan. See samples of the screening tools in the Files menu under Handouts and under Chapter 4. In assignment number 2, remember, you will use one of the screening or assessment tools to interview a person and write up your results. Because addiction can manifest differently in each individual, it's helpful for addiction counselors and mental health professionals to have a measurement tool for assessing problem areas. The Addiction Severity Index, ASI, was developed in 1980 by Thomas McClelland. It is a semi-structured interview with 200 questions in 7 potential problem areas. The 7 domains or areas of life covered by the Addiction Severity Index are medical, employment and education, drug use, alcohol use, legal status, family and social issues, and psychiatric. See the ASI versions in the Files menu under Handouts and under Chapter 4 on Screening and Assessment Tools. Your textbook talks about key areas to thoroughly explore when you are assessing a person's alcohol and drug problems. Number 1, does the client have a family history of alcohol or drug use or substance use disorders? This relates to genetics, family learning of coping skills, potential trauma concerns, adverse childhood experiences, and social environment. It is important to understand the family consequences of SUD. Number 2, what is the client's use of alcohol and drugs? What age did they start? What is the frequency and duration of alcohol and drug use? The set and setting. Any particular periods of severe use or of abstinence? Any episodes of previous treatment, counseling, and what was effective or ineffective? And number 3, explore all of the consequences related to drug and alcohol use. See page 132 in your textbook. This will also be helpful to determine the issues that will need to be repaired in recovery. These areas of consequences may also be considered triggering events for potential future relapses. A comprehensive list of consequences related to alcohol or drug use is on page 132 in your textbook. Become familiar with these signs and symptoms, consequences over the areas of a person's life. These are the types of things you will write down in your assessment instrument. While SUD may affect adolescents in different life areas, such as school or motivation, it is important to thoroughly review all of the consequences specific to youth. Recovery may be a rockier road for youth because the consequences may not have manifested themselves for very long. It is no less important to build the relationship and to develop honesty in tackling SUD. Many youth do recover. Review the number, name, substance use disorder, severity, mild, moderate, or severe, specifiers, in early remission or in sustained remission. Handouts on the criteria for the substance use disorders, worksheets, and definitions. See the handouts in the Files menu under Chapter 4. If you are going into the Alcohol and Drug Studies program, please become familiar with the 11 criteria that make up the symptoms of a substance use disorder. Although only licensed clinicians, such as LMFTs, LPCCs, or LCSWs, can do the actual diagnosing, it is important as part of a multidisciplinary team to understand the language and symptoms that you will be observing in the clients that you will be working with, even as a certificate or registered alcohol and drug counselor. Here are the 11 substance use disorder criteria. There must be a maladaptive pattern of use that causes impairment in the life domains or distress in the client. Think of the areas of consequences that we covered earlier in the PowerPoint. There must be a pattern that exists for a minimum of 12 months. There are 11 substances. Each are coded separately. Cannabis withdrawal was added in this version of the DSM-5. Caffeine use disorder and withdrawal was also added in this version of the DSM-5. Amphetamine includes methamphetamine. Name some of the opiates that you're familiar with. How about some of the sedatives, hypnotics, or anxiolytics? Anxiolytics are the benzodiazepines that you may remember from Chapter 3. The severity, as mentioned earlier, the more symptoms or criteria that the individual meets out of the 11 criteria, then the more severe the SUD. Here is the rating system. ASAM stands for the American Society of Addiction Medicine. This is a patient placement tool developed by Dr. Mee Lee. It is a multidimensional assessment around 6 dimensions to match the patient's severity of SUD with the appropriate level of treatment or care. This way, we are not over-treating. For example, in the old days, everyone had to have a residential inpatient treatment stay for the first 90 days. That's no longer true. Nor are we under-treating everybody. Everybody only gets to come in 1 time per week to see their counselor. That probably wouldn't do much either. These are the corresponding ASAM levels of care for treatment services in California. The levels of care are designed to be a continuum of care. For example, someone may initially need a residential treatment service because they currently don't have a recovery-oriented living arrangement. They stay in the residential treatment facility at level 3.1 for 60 days, let's say, and then moves on to intensive outpatient treatment, level 2.1, plus a recovery residence in the community. And then eventually they move to the outpatient level 1 treatment. Remember, the minimum effective dose of treatment is 90 days. That's over the whole continuum of care, 90 days. It doesn't have to be 90 days in just one level of care. And then, if the client relapses, they can go back up to level 2.1 intensive outpatient to get stabilized again, and then back down to outpatient at level 1. It is a continuum of care. Suicide and substance use disorders can co-occur, so it is very important to continually assess for suicidal ideation in the clients whom we see. Your textbook mentions that the key question is, what would prevent you from committing suicide? This question allows the conversation to go in the positive direction of preventing suicide. In addition, the client will give you the answers that you need to take the next steps in action planning. For example, if you asked what would prevent you from committing suicide, and the individual began talking about how they remember when they weren't so lonely when their dog was alive, we may be able to get that person to think about getting another dog in the morning, going to the shelter, and actually taking some action that the individual would find helpful. A no-harm contract may be helpful to use with the client in this situation. The research is varied on no-harm contracts, but ethically this is a solid option to do whenever you have been able to get to the client to the point of agreement. If the client is not able to discuss preventing suicide and any possible solutions, then it is always wise to call the Mental Health Evaluation Team, MHET, or MET, to come out for an official suicide assessment. The phone number for MET in our county is 1-800-838-1381. Read through some of these facts about suicide. Although they may be a little outdated, they will be on the quiz. Talking about suicide to someone does not make them more suicidal. In fact, you will be surprised that most individuals want to talk about their suicidal thoughts and plans. The main initial thing is to use your listening skills and see if you can get the individual to begin talking about the prevention of suicide and the reasons for their hopelessness. As they talk, you will gain clues, and you will need to remember these clues to pass along to others. If the individual has a well-developed plan to commit suicide, then it is time to bring in reinforcements. To coordinate a call to the MET team, it will take a coordinated effort between you, the client, your colleagues, and supervisor. Again, the MET phone number in our county is 1-800-838-1381. When you call, they can give you an estimated time of arrival. If you cannot wait for their arrival, the next thing would be to get the individual to the nearest emergency room, and then MET can show up there to do their assessment. If it is too dangerous to transport the person to the ER, then call the ambulance, police, or fire department. Let's go on to the discussion forum for Chapter 4 and then the quiz.